I'm going to discuss. I'm going to discuss about the I'm taking one example of Pandaroga from Ayurvedic point of view, and then I'm trying to incorporate with the Samprapti Ghataka of those things based on the etiology, based on the pathogenesis, and based on the clinical features. So we can come to certain conclusion that these are all some of the evidences to support that this may be the reason I'm comparing and correlating with that into the other aspects of it. So um, you know that anemia is a severe global health concern. Is usually caused by a shortage of red blood cells, which are usually required for the oxygen transport. So the modern medicine uses the hemoglobin and the RBC indices to diagnose the anemia, but in Ayurveda uses the Raktadhatu Kshaya and the Raktadhatu Dushti and the Panduroga. So in that, I'm going to start with the introduction about the RBC count, why RBC count is important to understand. And everybody knows that I will not go into the much details about that. The red blood cell count is the specific volume of the blood usually expressed in the millions, millions of cells per microliter. So it is also a very important diagnostic overall health indicator to detect various kinds of disorders. And it is also usually we call it as in the erythrocyte count. And these are most abundant cells present in the human body. And usually they are produced in the bone marrow through a process called as the erythropoiesis. So these RBCs are very important. This is safe. Because the size and shape variation is the clear indicate marker. So there is it's usually it's a bioconcave disc-shaped cells. So that lack a nucleus in their mature form. So this particular unique shape increases their surface area, allowing an efficient exchange of gases into it, and as a result of that, it is going to pass on the oxygenated blood to the various part of the body. So what is the main functions of it? Everybody knows that the transport of oxygen from lungs to the body tissues. It also carry the carbon dioxide from tissues back to the lungs. So this is usually made by the heme and the globin. It's a kind of protein. The heme and plus combination belongs to hemoglobin, and iron containing protein present inside the RBCs. So normal count, everybody knows that in case of males, it is 4.7 to 6.1. In case of females, it is 4.2 to 5.4. So what is the clinical significance of this? RBC count is usually, if it is reduced, it is called as erythrocytopenia. And the most common presenting symptom is the anemia. So what may be the causes which may be responsible? Okay.
Sir, screen is PPTs are not visible, sir.
PPTs are not
I mean,
visible.
no. I mean, this is introduction or PPTs are PPT. First PPT is there.
No, I'm PPT moving.
No, sir. On screen it is not visible.
PPTs are not moving. I think you selected the screen wrongly. Means multiple screen sharing is there. That is the reason it might be. Just make sure that the proper screen share should be there. It is not there. It is not getting changed.
Yes, sir.
Okay.
First PPT is only there, sir, on screen. Right.
Okay, sir. Now okay. Now change. Yes. It is very common problem. It's okay. Thank you.
Sir.
It is very common problem, so it's okay. We can understand.
Sir Badgi sir, please make slideshow. Please.
No, that's not slideshow only. I went, actually.
Now. Please make slideshow, sir. Right side.
अभी ठीक है सर, अभी ठीक है.
नहीं सर मैडम, स्लाइड शो घेऊ देत ना. स्लाइड शो पे क्लिक कीजिए सर.
वीडियो ऑन कर लो. वीडियो ऑन नहीं, वीडियो ऑन नहीं है. हाँ, entire screen. Up now, up then you have to go for sharing, na. No, but what about the PPTs? PPT अभी दिख रहा?
Yes. हाँ, स्लाइड शो पर क्लिक कीजिए बस.
सर स्लाइड शो मोड पे नहीं है.
अभी ठीक है सर, इट्स ओके.
अभी दिख रहा?
Yes.
It's moving?
Yes.
Now it's okay, no?
Yes.
Shall I move?
Yes, sir.
Okay.
Yes, sir.
Okay.
Yes,
Okay.
we can start.
Okay.
Yes, sir. Yes.
Okay. As I mentioned earlier, the RBC is very, very important indicator for the diagnosis of various disorders, especially if the count is reduced. It is called as erythrocytopenia, and it is one of the major important indicator for the diagnosis of the anemia. So, what maybe there are certain causes which may be leading to the loss of RBC count inside the body. Maybe some of the causes may be acute, some of the causes may be an chronic one. So usually acute causes are if there is an surgery, there is an excessive bleeding will be there. There is a trauma, there will be an excessive bleeding will be there. So in that may be the reason where there will be an acute blood loss will be there, and as a result of that, there will be count is decreased. And in case of the chronic, the peptic ulcer, piles, or the menorrhagia, in all these conditions where the gradual loss of the blood will taking place over the period of time, and that's considered as a chronic blood loss. The decreased production, especially if there is an the bone marrow disorders are there, especially this is very common in case of aplastic anemia, leukemia, myeloblastic syndromes, and nutritional deficiency where the iron deficiency is very, very common. That's hypochromic microcytic anemia. Features are seen in case of the iron deficiency anemia. So vitamin B12 and the folate deficiency causes the macrocytic hypochromic anemia. So in case of the anemia of chronic diseases, where the certain diseases can cause the anemia of chronic diseases like chronic kidney disease because of the decreased erythropoietin, chronic infections, cancers, rheumatoid arthritis, systemic lupus erythematosus, all those are diseases where there is an anemia of chronic diseases. The increased destruction is there in certain conditions where the hereditary sickle cell anemia, thalassemia, autoimmune hemolytic anemia, malaria. In all these conditions, there is an increased destruction of the RBCs. The clinical features usually presented by the patients are fatigue, weakness, and the pallor, and the breathlessness, tachycardia, and the dizziness. So these are all the which indicates about the erythrocytopenia, where the RBC count is reduced. So now we're going to discuss about the what are the conditions where in which you will get the RBC count is raised. That is a polycythemia rubra vera, that is erythrocytosis. So this again primary polycythemia rubra vera, that where there will be bone marrow disorders are there, especially in case of myeloproliferative diseases. And there may then number two, there may be in certain conditions where uncontrolled RBC production is there, and the body produces more the
original
RBCs to compensate the low oxygen level. So in that, due to in case of hypoxic conditions,
Zaitini
especially
madam, please
in case
mute
of the high
yourself.
altitude, chronic lung diseases, and congenital heart diseases, and the heavy smoking. These are all the conditions where in which you will get the there is an excess demand of the oxygen level, low oxygen level. So in those areas, so where you will get the increased count. So relative polycythemia is there, especially in case of the dehydration and the burn conditions. Usually the patient presenting with the clinical features in the
Sir, you are mute. Sir, Badgi sir. Badgi sir. Hello, Dr. Priyadarshini. Badgi sir.
mute हो गया कैसे mute हो गया okay who unmuted it was somebody else has made there I think somebody from there that side.
Okay sir, please start.
So as I discussed about the in case of the erythrocyte count, where we discussed about where the count is increased and the count is decreased. These two are the clinical conditions which we come across once you advise the patient for investigation. So we can look into these two aspects of it. So when it comes to the, as I mentioned earlier, so I'm going to discuss about the one particular disease where we can come to the conclusion that how we can interpret in terms of understanding of an Ayurvedic concepts with that of the clinical, considering the clinical features of the disease. So yeah, everybody knows that I'm going to discuss more about the anemia. The anemia is a disease where the most of the 30% global population is suffering from the anemia. That too, iron deficiency anemia. So everybody is aware that so in the particular this particular disease is characterized by the size of the red blood cell, because it's very important to diagnose the anemia depending on the size of the red cells to establish whether it is an what may be the probable etiological cause. So it is hypochromic, more likely an iron deficiency; macrocytic, more likely of vitamin B12 deficiency or folate deficiency. So that's why the size of the red cells is very important to understand. And these particular red blood cells in the bone marrow require a specific amount of hemoglobin before being released into the bloodstream. So if this can be done through the erythropoietin that stimulates the division of the red blood cell precursor in the bone marrow. And if the red cells do not acquire hemoglobin at the expected rate, so then they will divide more often and have a lower MCV when released into the bloodstream. So that is the mechanism which is going on inside the body. So that's why MCV is very important component. So MCV is a very good clear-cut indicator for the diagnosis of various kinds of anemias. The MCV is low due to the insufficient availability of the hemoglobin components, especially such as in case of the iron deficiency anemia, because this globin signs in case of the thalassemia, heme ring in case of congenital sideroblastic anemia, and poor iron utilization in the anemia of chronic diseases. Whereas in case of megaloblastic anemia is caused by a deficiency in the vitamin B12 or folate, because which limits the DNA synthesis. So the cytotoxic medications, especially and the bone marrow illnesses such as myelodysplasia, can limit the cell division in a similar way. So in these cases, cells hemoglobinize correctly but divide fewer times, resulting in the circulating red blood cells with a greater MCV values. So that's why the red cell membrane is a lipid bilayer, so that can easily interact with the plasma pool of the lipids. So like certain diseases, especially liver diseases, hypothyroidism, hyperlipidemia, pregnancy can result in the high lipid levels and the MCV levels, because reticulocytes are the larger than the mature red cells. An increase in their count, such as especially in case of the hemolysis, might cause an increase in the MCVs. So I'm going to discuss about the iron deficiency anemia. It's very important comparing the Ayurvedic etiology with that of the modern etiologies. So when it comes to the most of the etiological factors mentioned in Ayurveda, starting from the dietary factors to that of the psychological factors to that of the viharas, lifestyle factors and all those things. So everybody is aware that this particular iron deficiency anemia develops because of the iron losses, or either through diseases or physiological requirement that exceeds the absorption. So this particular disease occurs when there is an iron losses or physiological requirement exceeds the more absorption. So in that particular conditions, this particular disease is going to manifest. So when we teach the students, we usually talk about the Rakta Dhatu and the causative factors which are related only to that of the Pitta Vardhaka Ahara Vihara, and we talk about the Raktava Srotas, we talk about only the Rasava Srotas. But the main etiological factors which disturbs the Annava Srotas is very important causative factors that needs to be looked into. So one cause, maybe the gastrointestinal blood loss, is the most common cause in both men and women after the menopause. So if you go through the Panduroga etiological factors, where it has been clearly mentioned, are Kamla, Lavana, Katu, Tikta, Tiksna, Usna. These are all the etiological factors which are indicating the gastric disturbances, gastric irritations, gastric disturbances. So those are all the factors which might be responsible for the development of the anemia in the Panduroga. So what are the causes? What has been mentioned in the modern medicine also, like stomach or the colorectal cancer, gastritis, peptic ulcers, inflammatory bowel disease, diverticulitis, polyps, angiodysplastic lesions. The hookworm infestation is also one of the major causes, which schistosomiasis are the leading cause of the intestinal blood loss. These two parasites are mainly responsible for that. So whatever the etiological factors mentioned in Ayurveda, whether it may be an improper purification, if you are not following the seasonal regimens, and if you are suffering from the kama, krodha, lobha, moha, these are all some of the psychological aspects of it. And the reading that is leading into the loss of the intestinal flora, and that is resulting into these things, or in the form of the if you are not following the seasonal regimens, and if you are not following the proper dietetics and all those things, that is resulting into the intake of the food which are contaminated with the parasites in the form of hookworms and the schistosomiasis. And the dietary factors which has been mentioned are of the amla, lavana, katu, tiksha, kshara, ati, lavana, tiksna. These are all the indicative of the kind of the food which you are eating are predominating with this or lacking calories, and that may be responsible for the iron deficiency anemia. So not only the dietary factors, not only the surgical aspects of it, not only the structural abnormalities which is taking place in the intestinal tract, there are certain drug consumption. The people who are taking the medicines in the form of aspirin and NSAIDs can worsen the gastrointestinal blood loss in the longer run. So that's why the chronic usage of this aspirin or the NSAIDs can worsen the gastrointestinal erosions and impair platelet dysfunctions. So what the dietary factors mentioned in Ayurveda are making the worsening the gastrointestinal erosions, and that is resulting into the blood loss. Menstrual blood loss, pregnancy, and lactation can all lead to iron deficiency in the women of the reproductive age group. And in the rich countries, especially the 1/3 of the premenopausal women have the insufficient iron storage. That is very important factor, because only the 3% have an iron deficient hematopoiesis. So really, in certain conditions, the prolonged hemoptysis or the hematuria might also cause the iron insufficiency. So there are certain diseases, maybe the person who is suffering from the malignant conditions, maybe suffering from the uncontrolled tuberculosis. In all those conditions, so that may be the causative factors for the loss of blood. Another important aspects to be looked into when you are looking into the causative factors. When another important is when you are eating the food, when you are taking the food, but that is not going to be absorbed properly. So for absorption also, in that has been clearly mentioned, especially the milk and the antacids or the PPIs are limiting the iron absorption. So that also should be strictly avoided, or the excess intake of that. For example, if the meat and other non-veg products are rich in iron, but in case of if you're taking in palak, paneer, and all those things, palak is rich in iron, but when you are combining with that of the paneer, that iron absorption is going to be decreased. So that's why you should facilitate the absorption mechanism. So that's why the vitamin C is very, very important for the vitamin C rich foods, or the vitamin C is very, very important for the absorption of the proper absorption of the iron. But in certain conditions where usually this may be the reason where you are taking a sufficient amount of iron, but you are not following the things to be. That's the reason the kids comes with they are taking too much of milk, and that's the reason the iron level is less in that particular child. So that's why it's very important absorption. If we are making in that, these things should be keep into the mind when you are looking into the history of the patients. Because this gastric acid releases an iron from the food and maintains maintains its soluble ferrous state. So the achlorohydria, especially in the elderly patients, makes the like proton pump inhibitors, as I told earlier, and the post gastric surgery can all lead to the iron deficiency in the diet. That's the reason that history is very, very important. Celiac disease can disrupt the active absorption of the iron in the upper small intestines. So the iron deficiency anemia is commonly seen in physiological conditions also, like during the phase of fast growth, maybe in case of infancy and the puberty, iron requirements can exceed the absorption. So that may be the reason where iron deficiency can develop in these conditions. And iron is in case of pregnancy, usually what happens, the iron is diverted to the fetus, placenta, and the maternal red cell mass. So that is why it is then eliminated during the parturition through the bleeding. So the clinical features of the iron deficiency is very, very important. When you are making an clinical conditions, likelihood of iron deficiency is the pregnancy, adolescence, period of rapid development, and intermittent history of any type of blood loss should all looked into when you are taking the history of the patients. The general guidelines is that in case of the adult male, the gastrointestinal blood loss, unless they approve otherwise, because the iron deficiency anemia in case of the adult male, because of the peptic ulcer disease, that also needs to be looked into. That blood loss is going to be developed through the gastrointestinal tract. So that's why iron deficiency symptoms. So that's why it differs from the severity and duration of the anemia, since how long the patient is suffering from, and what is the severe nature of it, how much reduction of the RBC count and how much reduction of the hemoglobin percentage. So because the patient comes with a typical presentation is the fatigue, pallor, and the decreased exercise efficiency. These three are the cardinal features where the patient presenting with that. So in there are certain patients where if it is a long term, then there will be chylosis, fissures in the corner of the mouth. Chylonychia, so spooning of the fingernails, indicate a significant tissue iron shortage. Iron deficiency is usually recognized through the laboratory test, because sometimes the patient, you may not get the classical signs of the fatigue, pallor, and the decreased exercise efficiency. The investigations, what are the investigations are to be done to diagnose it as a case of the iron deficiency anemia? That the plasma ferritin is very, very important measure of the iron storage in the tissues, and it is the most effective most test for confirming the iron insufficiency. So that's why the subnormal level may indicate the iron insufficiency, hypothyroidism, and the vitamin C deficiency. So in case of the liver disorders, where the acute phase response, the ferritin levels can reach up to 100 microgram, while the bone marrow iron reserves remains the lower. So the plasma iron and the total iron binding capacity are indicators of iron availability that are influenced by various factors other than the iron reserves. So the plasma iron levels fluctuate through the day and may drop during an acute phase response. So that's why it can increase during the liver disease and the hemolysis conditions. So the malnutrition and the liver diseases, acute phase response, and nephrotic syndrome lower the transferrin level. But in case of pregnancy and oral contraceptives can raise them. A transferrin saturation, especially the iron and the TIBC times 100 of the less than 16 suggests the iron deficiency, but is less specific than the ferritin testing. So serum ferritin is the important one of the important tests for the diagnosis of the iron deficiency anemia. So this all depends on the patient's age, gender, medical history, and the clinical results. The another important thing is, until and unless you evaluate the causative factors which is responsible for the development of the disease, you cannot treat the diagnose, or you cannot treat the disease. That's why it's very, very important to identify the root cause. That's why endoscopy is very, very important to rule out the peptic ulcer disease. Radiographic examinations of the upper and lower gastrointestinal tract should be conducted in both men and the postmenopausal women who consume a normal diet. In certain individuals where the celiac disease is diagnosed using the serum anti-endomysial or anti-transglutaminase antibodies and a duodenal biopsy. So in the tropical countries where the very, very important is go for an occult blood test and the urine for the parasite. Both stool and the urine you should look into, examine for the parasites. The another disease is the megaloblastic anemia. So this can be diagnosed. This may be caused by the vitamin B12 deficiency or by the folic acid deficiency, and as well as issues with the folic acid metabolism also. If there is a defect in the folic acid metabolism, that can also cause the megaloblastic anemia. The folate and the vitamin B12 combine to convert homocysteine into the essential amino acid methionine. So the megaloblastosis is the affect all the proliferating cells, causing the abnormalities in the buccal mucosa, tongue, small intestine, cervix, vagina, and the uterus. That's the reason you can get the findings in these areas. So this megaloblastic alterations are particularly visible in the early nucleated red cell precursors. So hemolysis in the bone marrow causes the elevated bilirubin and lactate dehydrogenase, but not the reticulocytosis like other types of the hemolysis. So iron stores are typically raised in this megaloblastic anemia. Mature red cells are large, but in case of the iron deficiency anemia, the mature red cells are smaller in size. Here, in case of megaloblastic anemia, the mature red cells are large, oval, and may contain nuclear remnants. The immature granulocyte precursors exhibit the nuclear alterations and resemble the giant metamyelocytes with large sausage-shaped nuclei. So that's why the mature neutrophils have the another important indicator is the hypersegmented nuclei of the neutrophils with 6 or more lobes. The severe cases may show the pancytopenia in the peripheral blood smear examinations. So the vitamin B12 deficiency, but not the folate deficiency, is linked to the neurological disease in up to 40% of the cases. The significant neurological disease from the vitamin B12 deficiency is uncommon in the developed world, but it is common in the developing world. Sensory symptoms include the peripheral anesthesia and the ataxia of the gait. What are the classical signs and symptoms which you get in case of the patients of megaloblastic anemia? Is the malaise, breathlessness, paresthesia, sore mouth, weight loss, altered skin pigmentation, especially the between the in the hands. You can just look into impotence, poor memory, depression, personality change, hallucinations, visual disturbances. These are all the common clinical presentations patient come across with that. So what are the the examination signs you will get? The tongue become very smooth, angular chylosis will be there, vitiligo, and the skin pigmentations, heart failure, and the pyrexia. These are all the very common presentations, common examination points which you get in case of the patients. So as I mentioned earlier, so just the symptom, I'm showing the pictures where the patients are showing the spoon-shaped these things, and the palmar area where you can see that the pictures, and again it's going to help to identify the pallor. So that the two pictures are given. One is a pallor palm, and the another one is a normal palm. So the pallor is clearly visible, and in the another picture which is clearly visible is the spoon-shaped. The oral manifestations, when a patient comes to you with an history of the anemia, or you should always look into the mucosa and the gingiva, and the tongue examination is very, very important. There is a typical redness, soreness, or burning of the tongue, but in case of the oral mucosa and the gingiva are to be properly examined. As I mentioned earlier, that the oral presentations. Recurrent aphthous ulcerations and the candida lesions can occur in case of the iron deficiency anemias. The Plummer-Vinson syndrome, where you can see the nails important, examination is very, very important. But here, the iron deficiency, the dysphagia, iron deficiency anemia, and dystrophy of the nails and the glassitis are the clinical features you should always look into. The other points, the cracks, the fissures at the corner of the mouth is very, very important things to be looked into. Along with that, the lemon tinted color of the this thing. So how can we correlate with the in case of the Ayurveda? So where there is no direct term, it has been directly as red blood cells, but in Ayurveda it has been mentioned as the Rasadhatu and Raktadhatu. The functions attributed to the Rasadhatu and Raktadhatu may be correlated with the functions of the blood. So when it comes to the red blood cells, where the functions of the rakta, raktam jiva iti sthiti. The same has been told to the what the hemoglobin present in the RBCs, which carries the oxygenated blood. So what is jiva iti? So jiva is which gives an oxygen to the cells. So in that way, so just RBC maintain the oxygen supply. Rakta dhatu also sustain the same. The functions is same in terms of that. So the Rakta is responsible for Jivana, Varna Prasadana and Pusti. The same functions are done by the RBCs also. In that way, we can correlate with that. Any variations in the RBCs, that can be correlated with the variations in the Rakta Dhatu also. So when you are interpreting the results of that, so these, because RBCs are formed from the bone marrow, in the Rakta Dhatu is formed from the Rasadhatu. Then there's Ranjaka Pitta, that is mainly in the Yakrut and the Pliha. But the dietary factor is very, very important. The dietary source, what has been told from the during the metabolism, during the Dhatu Agni Paka, so that from the Sadhatu, then it's going to be formed. Rakta Dhatu is going to be formed. Due to the Asri Bhava Rakta and Pitta, the Vishesha, that's why when you are looking into the clinical features, you should always look into the Asri Bhava Prasad Rakta and the Pitta Dosha. So any variation of the Rakta, especially the RBC abnormalities, impaired tissue oxygenation, that is resulting into the Dhatukshaya and then resulting into the Vojakshaya, that results into the Balakshaya or the Balahani or the Vadik Shamatva Hinata will be there. So the decreased RBCs, that can be correlated with the Raktadhatukshaya, that can be correlated in case of the Panduroga, that can be compared with that of the Raktavruta Vata. But the presentation of the Raktavruta Vata can be seen in case of the megaloblastic anemia features are there. Decreased RBCs can be seen in case of Raktaruddhi, and the Pitta Dushti Lakshanas are mimicking with that. So when a patient presenting with, when you are making an interpretation of any blood test, you should always look into the clinical presentation. Based on that, we can correlate with that. Take for example, we can correlate the Raktavruta Vata and the, for example, I'm going to explain about the Raktavruta Vata. So this Raktavruta Vata clinical features are Suchibirivan Istodaha. So this particular, the Suchibirivan Istodaha, that pricking pain, Sparsha Dvesa, that is an touch intolerance, and the numbness and other the Pittaja disorders which are going to manifest here. So this particular presentation which you can find it in case of the vitamin B12 deficiency features. So based on that, we can correlate with that. So this is maybe a vitamin B12 deficiency that can be correlated with that of the Raktavruta Vata. So when you are writing the interpretation of that, so there is a Rakta Vata got avarna by the Rakta Dhatu, and as a result of that, it's going to manifest. Again, further it has been mentioned that Pitta Vikaraha Shu Marute Sonitani. So it is also going to manifest the other Pittaja Vikara or the Pittaja conditions. That is one of the example where you can quote is the megaloblastic anemia. So the modern medicine also says that vitamin B12 deficiency causes the numbness and tingling in the hands and feet, burning sensation, walking difficulty, weakness, fatigue, glossitis, and the congenital and the cognitive behavioral changes we can get in case of the advanced conditions of the anemias. So to make an interpretation of these diseases with that of the Rakta Dhatu, there is an Rakta Dhatu got an Margavaruna par Vata dosha, and that is making an hindering the movements of the normal movements of the Vata, and that is resulting into the abnormal neurological functions, resulting into the manifestation of Prasuptata, that is nerve demyelination, resulting into the numbness and avarna of the Vata. Because of that, the sensations which needs to be passed on, that has been hindered by the Rakta, and then as a result of that, the patient will, because of the lack of blood in that particular area, resulting into the loss of sensation. The Suchibiriben is to the heart, tingling and pricking sensation, that is a vital peripheral neuropathy. Pins and needles will be there. In Ayurveda, it has been Tiksta Vedana in case of the Rakta Vrutavata. Sparsha Vidvesa, where the patient hyperesthesia and allodynia, where the vitamin B12 altered nerve signaling will be there. Hypersensitivity, that it can be compared with that Vata and Rakta. So that is resulting into the touch intolerance. So the burning sensation, maybe the burning feet syndrome is frequently observed. So that's why it has been told Rakta plus Pitta involvement. The Pittaji Vikara has been told in case of the Rakta Vrutavata. So that is all the Tosa, Chosa, Paridaha. These are all the presentations are because of the Pitta dosha. So to take an example of the Panduroga, how we can interpret in terms of the clinical interpretation, considering the reports in front of you, you're diagnosing it as in case of Panduroga, whether it is an megaloblastic anemia or whether it is an iron deficiency anemia, based on the examination findings. But always when you're looking into when you're making an interpretation of the dosha and doshas, you should always interpret along with the clinical presentation of the patients. So the clinical presentation is very, very important. That should be looked into. Though, for example, the Hridaya Spandanam, it may be because of the Vata, increased Vata functions. Raukshata is again increased functions of the Vata. Sweda Bhava, again it is because of the Pitta decreased and Kapha is increased. The Srama, it is again because of the Kapha increased. Karnak Sweda, that is again because of Vata is increased. Hatha Analaha, there is a decreased functions of the Agni, that may be because of the Kapha is decreased. Kapha is increased and Pitta is decreased. And Durbala is again because of these things. So the dhatus involved is the Sweda Bhava is maybe because of that's why Alparakto, Alpamedasko, Nisaraha, Sitilendriyaha. So where the Rasa and Rakta and the other dhatus are get deranged. But based on these presentations, we can say that Hridaya Spandanam is because of the Rasa dhatu. Raukshata is again in case of if we're going into the comparison with that of Rakta dhatu, Sweda Bhava for Meda, Srama for Rasa, and Karnak Sweda. In case of Rasa dhatu Kshaya, it has been mentioned there. So the Rasadhatu Dusti, where the Hatanala will be there, Durbala. These are all some of the presentations. You should, when you look into it, consider the investigations, look into the Lakshanas, and then you can interpret which dosha and doshas are involved. Same way, Sadhana, it is again Kapha decreased and the Rasadhatu involvement. Annadvit, aversion to fit, again Pitta decreased and Kapha Dusti will be there and Rasadhatu involvement. Kapha increased because of the Kapha increasement, there is Srama, fatigueness will be there. Giddiness, dizziness, these are all because of the Pitta increased conditions. Fever, again, increased metabolism will be there. That's going to cause the Pitta increased and Rasadhatu will be there. Aruchi is again can be interpreted with that of the Pitta is getting to be decreased and Kapha will be there. And Sunakshikuta Sota Vata is increased and the Medadhatu along with that. So to conclude that, they make an interpretation when you're making it's a Pitta Prakriti, Pitta Vikruti plus Vata Prakopa, and the Kapakshaya Dhatu analysis will be there. Pramukataha, mostly the Rasadhatu is mainly involved in the manifestation of this particular disease. So Rakta Dhatu Ruddhi Lakshanas are mentioned in Ayurveda is Rakta Ruddho to Raktangata Daha Sravascha Jayate. So that is the Raktangata Daha. Raktangata is a reddish discoloration because of the RBC count is more. Burning sensation, Pitta association, and Srava, there is a tendency for the bleeding. These are all the So this can be increased quantity and activity of the rakta similar to the RBC count is increased. So in case of Charaka Samhita, so it has been clearly mentioned that Tatra Sonida Duste Daha Paka Raga Sravaha Daha Paka Raga Sravaha. So this indicates that visual and qualitative change in the blood, especially it can be seen in case of the polycythemia conditions, polycythemia rubra, where there is an increased viscosity and altered flow, hence correlates it with that of the Rakta Dusti. So Rakta Pitta relations, as I mentioned earlier, when it comes to the Raktasam Pittasya Asrayaha. So when you are making an interpretation of that, Rakta Ruddhi, Pitta Ruddhi features like redness and the heat may be seen in that. So the patient may present with flushing, burning, and the lalima, redness will be there in the particular localized area. So to conclude that, Rakta Dhatu Ruddhi is seen in case of polycythemia, the increase in RBC count, hemoglobin and the hematocrit values will be, and in Ayurveda, increase in Rakta Dhatu quantity, Drava plus Sarabhaga of the Rakta will be increased. That best fits for the polycythemia or best fits for the Rakta Ruddhi Lakshanas, comparing the both of the conditions. So I'm going to, this is about the, discussed about the interpretation of the anemia with that of the Panduroga, which I tried to made it out. Now I'm going to discuss about the one case and then a patient. I'm taking on one example why the Annama Srotas should be given more importance to the cases of anemia. So anemia means you should not look only into the aspects of the blood. You should always, the patient should be examined for the Annama Srotu Dusti. It is very, very important. Take for example, one patient named XYZ with 30 years male, residing somewhere. So having and complaining of vomiting and abdominal pain since last 1 day. They're suffering from fatigue and generalized weakness since last 5 days, and dyspnea and exertion since last 5 days. This is the clinical chief complaints of the patient. So this patient was apparently asymptomatic for 5 days prior to the presentation, after which he developed gradually progressive fatigue and generalized weakness accompanied by the reduced appetite. He subsequently developed exertional dyspnea, which was insidious in onset, initially relieved by rest, but progressively worsened to orthopnea and paroxysmal nocturnal dyspnea. So suggestive of the worsening cardiorespiratory compromise. So it indicates that severity of the, this is the clinical presentation is indicating the advanced severe anemia with the advanced severe condition. So since 1 day prior to the admission, the patient experienced the multiple episodes of non-projectile vomiting occurring shortly after food intake, containing undigested food particles with no history of the hematemesis. So the history of present illness, this was associated with acute onset of epigastric pain, described as intermittent, non-radiating, and aggravated by food intake. Additionally, the patient reported dysphagia and the constipation, along with the single episodes of passage of black-colored stools, suggestive of the melena. So there was no history of abdominal distension, diarrhea, fever, cough, or any neurological symptoms such as headache, loss of consciousness, altered sensorium, paresthesia, focal neurological deficits. There is no chest pain, palpitation, breathlessness, cough, and the fever. So in the fast history, the patient no history of the diabetes or hypertension, no history of cerebrovascular accident earlier, no known case of bronchial asthma, and no history of the tuberculosis and the fast surgeries. The patient is taking the warfarin, olmesartan, aspirin, clopidogrel, atorvastatin, and metformin. These all drugs is going to cause the anemia. So that's why when the patient, taking the history of the patient comes to with an history of anemia presentations, the drug history is very, very important. If this patient is not taking the phenytoin, I have mentioned to convey you that if the patient is taking the phenytoin for the management of epilepsy for a longer time, so that is going to cause the megaloblastic anemia. So that is why take the drug history is very, very important. If it is the patient is taking phenytoin for years together and that developing in megaloblastic anemia, that the phenytoin should be the causative factor for the development. That's why the drug history is very, very important. How this warfarin is going to cause this is the important factor. This is going to make the bleeding, and that is related to the iron deficiency anemia, because which inhibits the vitamin K dependent clotting factors that increases the GI bleeding, intracranial bleed, and the occult bleeding. So as a result of that, there is a chronic blood loss and resulting into the iron deficiency anemia. So occult GI blood resulting into the gradual hemoglobin percentage. Another drug is the aspirin. Mechanism is the gastric mucosal damage plus bleeding, which inhibits the COX and the decreased prostaglandins, decreased gastric protection, causes the gastritis, ulcers, resulting into the GI bleed and the iron deficiency anemia. Also causes platelet dysfunction, and this also worsens the bleeding. Clopidogrel. Clopidogrel increases the bleeding risk, inhibits the platelet aggregation, and leads to prolonged bleeding, occult blood loss, and that is resulting into the anemia. Especially risky when combined with the aspirin dual therapy. So combining with clopidogrel with that of the aspirin. Usually patient take. Mechanism is olmesartan rare malabsorption anemia can cause this pro-like enteropathy, leads to the chronic diarrhea, malabsorption, iron orbital deficiency anemias, but rarely rare incidence is very, very rare. Atorvastatin is again one of the drug, rare but indirectly causes the hemolytic anemia, bone marrow suppression. Metformin, if the patient is who is on the metformin, you should always check the vitamin B12 deficiency. The long-term use can cause B12 deficiency and leading to the medulloblastic anemia. So the personal history, the patient prior to that patient appetite was, but now the appetite is reduced. There is sleep was normal. The constipation was present in the patient. No significant family history was found in the patients. So on examination, the patient, the pulse pallor was present. The patient was having the tachycardia. The hyperdynamic pulse will be there in case of in this patient also. It has been observed that severe hyperdynamic bonding pulse was observed. The thready pulse, if the thready pulse is not there in this patient, but thready pulse can be seen in case of the patient because of anemia going into the shock. White blood pressure, it's very, very important. The systolic is always in the normal range, and the diastolic pressure is in the lower range, because of the hyperdynamic circulations, That's why but in this patient, it was 130 by 70 or 60 like that. So it may appear, the temperature may appear increased due to the high metabolic rate. In case of the anemia, due to the high metabolic state, the patient complaining of the febrile situations. So there are 5 areas to be looked into: lower palpebral conjunctiva, oral mucosa, soft palate, tongue should be examined, and the palms, the loss of palmar creases, and the nails should be looked into to look into the paleness in these areas. The oral cavity, as I mentioned earlier, oral cavity and the tongue are very, very important. Glassitis, especially the smooth, bald, red tongue. Angular cheilitis is very common in case of nutritional deficiency in iron and B12 deficiency. Nail changes is very important. I have shown the picture earlier also. Spoon-shaped nails, iron deficiency. It was there in this patient also. Flapping nails, it's very rare. It was not there in the patient. Knuckle pigmentation, it's very, very important, in between the knuckles, this is a very, very important clinical feature. So that can be knuckle pigmentation is very, very important, clear-cut indicative of the vitamin B12 deficiency. That's why when your knuckle should be examined properly in case of the vitamin B12 deficiency. Seen in case of icterus can be seen in case of hemolytic anemia, but cyanosis and the clubbing are usually absent. In this patient also, it was not there. The lymphoreticular system also needs to be examined, especially in case of the lymphoma infections or sarcoidosis. There also you can get the splenomegaly, especially is very important in case of hemolytic anemia, infections, and hematological malignancies. So hepatomegaly may be seen in case of the chronic hemolysis or the systemic diseases. The tachycardia, as I mentioned earlier, hyperdynamic circulation will be there. Flow murmurs, functional systolic murmurs are seen in case of the anemia patients. Signs of high output cardiac state will be there, and peripheral edema due to the fluid overload. Then because of the cardiac strain. So gastrointestinal tract should be properly examined to look into the hepatomegaly and the splenomegaly. Central nervous system, it's very important to differentiate with that of the iron to that of the folate deficiency, vitamin B12 deficiency. That's why loss of abrasion sense is very, very common features. So to conclude the condition, the patient was generally well oriented to the person, place and time. Vitals were 83 per minute regular, with the respiration rate was that, blood pressure was 150/70, afebrile, altered behavior is present, with the dementia observed in the vitamin B12 deficiencies. So these are all I repeated. So that when you were making a complete blood count of this particular patient, where it has been noted that the mean corpuscular volume was decreased, and the mean MCH values, mean corpuscular hemoglobin, has also decreased. So it's most commonly it is it is more likely in case of iron deficiency anemia. So the serum iron also, it is also decreased, where the patient ferritin, as I mentioned earlier, ferritin level is very, very important, but TIBC is increased and the serum ferritin level is decreased. Again, this also make an important clue for the diagnosis towards the iron deficiency anemia. But occult blood test was it was also positive. That indicates that there is a chronic gastrointestinal blood loss. So this is a very important indicator clue for the patient who is having an episodes of vomiting, and that's for one day. Then he gradually developed the fatigue and the restlessness and the breathing difficulties. So that means that the gradual blood loss was taking place through the gastrointestinal tract. So the upper GI endoscope was also done in this patient. That was indicated the gastric peptic ulcer disease. And other than in other patients, we may get the gastritis or the malignant conditions. So these are all the thing which indicates that there is a blood loss either from the peptic ulcer disease or gastritis or due to the malignancy, and that is going to cause the iron deficiency anemia. So along with that, the coagulation profile is also very, very important. Prolonged PT-INR is also suggesting that coagulopathy, increased risk of bleeding will be there. Liver diseases, where vitamin K deficiency, anticoagulant therapy, especially as I mentioned earlier, warfarin and all those drugs, and that is leading into the chronic blood loss, causing the anemia. So the suspected bleeding disorders should be looked into. Patients, if they are taking any anticoagulants and unexplained melena or hemorrhage is there, that patient needs to be properly examined. So peripheral blood smear is very, very important examination for the diagnosis of anemia. Should look into the RBC morphology, WBC and platelet abnormalities. So that is very, very important to make a classification in the pathological diagnosis. So microcytic hypochromic RBC features are seen in this particular patient. Again, that is indicated towards the iron deficiency anemia. But if it is in macrocyte, if it is in vitamin B12 deficiency, then you get the large RBCs. That suggests the vitamin B12 deficiency or the folate deficiency. If the target cells are seen in the peripheral blood smear, that indicates the liver disease or thalassemia. And if it is spirocytes are there, that indicates the hemolytic anemia, that is hereditary spirocytosis. The cystocytes are seen, the fragmented RBCs, that indicates the microangiopathic hemolytic anemia, and hypersegmented neutrophils. As I mentioned earlier also, the hypersegmented articles with the size and shape of the RBCs is increased. That is indicating towards the diagnosis of the megaloblastic anemia. So to conclude, in this particular patient, the patient was having a history of melena that was indicating the GI bleeding. How to differentiate whether it is a bleed from the upper GI tract or the lower GI tract? If the patient presenting with the fresh blood, so then that is indicating the bleeding from the lower GI tract. So in this particular patient, the patient was having the melena. So getting the upper GI tract bleeding is there. So in this patient, the patient was also taking the warfarin and other antiplateletic agents. That was also increasing the risk. And the patient presentation was also dyspnea, fatigue, and pallor. That is indicating towards the diagnosis of the anemia. The patient is developed the orthopnea and the paroxysmal natural dyspnea. So these all mimic the cardiac cause that can seen in this presentation. Not the patient in this patient had is indicating the cardiac involvement also. So that's the reason the advanced progressive condition of the disease. So that's the reason when you're making anemia in failure due to fluid overload. So the anemia secondary to the upper gastrointestinal bleeding, that we can specify anemia in failure due to the fluid overload. The differential diagnosis, as I mentioned earlier, with how to differentiate with these different conditions. Suggested investigations, as I already discussed these investigations, what has to be done in this particular patient: serum studies, vitamin B12 and folate levels, stool occult blood, upper GI endoscopy, coagulation profile, peripheral smear. So the final impression is it is a case of symptomatic anemia likely due to upper gastrointestinal bleeding, possibly aggravated by the anticoagulant antiplatelet therapy. So that's why when you are taking the history, the history should not rely only on the diet, but the dietary factors, what has been mentioned in Ayurveda for Pandaroga, all are gastric erosive diets, so that may be causing the hindering in the gastrointestinal tract, and then that may be get aggravated by the intake of certain medications or intake of the certain dietary factors and certain psychological factors also. So management of anemia, that is also, I'm going to talk about the management perspective also, because until and unless you understand the management also, you cannot understand the disease in total. The severity of the anemia, the hemodynamic stability, and then evidence of the ongoing bleeding, that should be done. If the unstable, urgent resuscitation with the IV fluids and the blood transfusion, if it is necessary, go for that. Otherwise, because it all depends on the hemodynamic stability, depends on the severity of the anemia, and if there is an evidence of the melena. So treat the underlying cause, most important. Treat the underlying cause. If it is because of peptic ulcer disease, treat the peptic ulcer disease first. If it is because of H. pylori, eradicate that H. pylori. So treat that. If it is erosive gastritis, treat that. That's the cause should be eradicated. So if the patient is on proton pump inhibitor, eradication of H. pylori is present. That is very, very important. And the stop appendix drugs, like if the patient is taking the other, already I mentioned clopidogrel, warfarin, NSAIDs, aspirin. These are all the drugs. Maybe if the patient is taking metformin, if the patient is taking the Phenytoin, these drugs should be stopped, those appendix drugs, until and unless you stop that causative factor. That's the reason treating anemia alone without treating the cause. That's the reason in Ayurveda it has been mentioned that Sankshepata Kriyayogo Nidano Parivarjanam. So treat the causative factors, identify the causative factors, and then accordingly go for the treatment. So again, the treatment is very, very important. If the patient is suffering this, in this particular patient, the patient is diagnosed as anemia because of the peptic ulcer disease, plus drug-induced bleeding and all those things. So oral iron, if you are giving an oral supplement of iron, so that cannot be absorbed into the system and you cannot treat the patient. So not prepared initially until and unless you treat that particular conditions, the urine peptic ulcer disease, the iron absorption will not take place in the oral cavity, in the gastrointestinal tract. So that's why in these patients, the patient should be treated with parenteral iron either through IV or IM. The preferred example is the iron sucrose ferric carboxy maltose. They continue the iron therapy until the hemoglobin normalizes up to 1 month, plus additional 3 to 6 months. Very important. Once the patient reaches the normal stage, don't stop the treatment. Continue for another 3 to 6 months to replenish the iron stores. And the important concept is especially when you are giving an IM injections, that is the jud shaped, that is, you should retract the skin and then give the injection and then remove that, jud shaped, that precaution needs to be taken when you are giving the in the gluteal region IM injection. When you are giving the typical injection pattern needs to be followed in the these patients. So the correction of the HB and the correction of the RN stores is very, very important. So the early response, usually the count ranges within 48 to 72 hours, not the HB percentage. Only the reticulocyte count may range. But the 1 to 2 gram of hemoglobin per DL may be raised over a period of 2 to 3 weeks. Repeat the investigation. That's the reason. Don't do it once you have started the remedy and then you will start the next day or tomorrow. No. Wait for 2 to 3 weeks and then again repeat the investigations. Once the patient hemoglobin percentage is increasing, then it indicates that patient is responding and the causative factors has been removed. Then the blood transfusion, if needed, especially in case of severe anemia, if the hemoglobin percent is less than 7, and if it is symptomatic, dyspnea, cardiac compromise conditions will be there, active bleeding will be there, then that needs to be taken care. And follow-up cases, again, periodical testing of the HB levels, iron stores, especially the ferritin, ensure the ulcer healing, or if it is an deworming therapy is required, go for a deworming therapy. The causative factors needs to be looked into, and then that should be taken care. So I extend my sincere and heartfelt gratitude to Dr. Jyoti Megdambar and Dr. Renka Savan for their exemplary efforts in organizing this online webinar. So their unwavering dedication, meticulous planning, and the exceptional academic commitment were instrumental in the seamless execution and success of this program. So I hope their vision, coordination, and tireless efforts are truly commendable and deeply appreciated. So I also extend my thanks to my residents, Dr. Rangaswamy, Dr. Palak, and Dr. Rutu, who helped me in preparing the PowerPoint slides. And I'm truly thankful to all who contributed directly or indirectly, because I'm saying this, I have collected lot many information through the video lectures, from the textbooks, from the published articles. So I'm thanking each and every person who contributed me to prepare this lecture. Thank you, one and all. If any questions are there, I'm happy to take that. So now it is open for any discussions. Over to you, Dr. Renukaji.
Yes, sir. Yes. Thank you so much, sir. I request participants, if there's any doubt, there are any queries, please write them in the chat section.
I hope I finished my lecture on time. Eh?
Yes, yes, sir. Participants, you can ask your queries in the chat section. I please request you to don't hold back or don't hesitate, because all these knowledgeable speakers we have here at a very accessible range to you. You pay in case when you hear them out in the different seminars or workshops, but they are very available at the accessible range to you. So please don't hesitate. If there is any query, any doubt, please ask right now. Yes. Is there any doubt? So shall we proceed then?
One minute, huh?
Okay.
Dr. Jyoti madam is saying something.
Dr.
Yes,
Renuka, one question is from the PG student of Ayurveda College, GSC Nanded.
Yes, please.
He is written in chat box, I think.
Okay.
Okay, that's
also,
how we can correlate thalassemia in Ayurveda. Okay. So as I mentioned earlier when I was showing my slides actually, so the thalassemia is a condition where it is developing because of the bija dusti janya vikara. So where there is the defect is there in the manifestation of the iron store in the through genetic these things. So genetic deformities is there. So genetic abnormalities where that cannot be treated or that can be only managed with the blood transfusions. But in their conditions also, where based on the clinical presentations, where we can say that some of the factors mentioned there that should be looked into based on the clinical presentations of the patients, that can be correlated with the dosha mechanism there. But it is an again Bija Dushtijanya Vikara. It is an asadhya vyadhi, and that needs to be managed with these things. So somebody is asking which book should we prefer Ayurvedic interpretation. So I think I already published clinical manual, laboratory clinical manual. So that can be available through the Chokamba. And we are also coming up with one more book that is from the Dr. Jyoti and myself and Dr. Aishwarya, all three executive editors are coming up with that. So we are making the combination of all the investigations, and we made an effort to make an probable possible interpretation of each and every test. So you can, I hope it will be made available to all within a short period of time. Okay. So I think pre-test had been given. I think how many students have been participated in the pre-test and how they, what is their response and how much they scored, and then now it is open for post-test.
Okay, I think we'll proceed with the attendance form. Link is been posted in the chat section. I request participants to please attempt the post test and fill up the attendance form. Okay, so yes, now we'll proceed with the co-chairperson and chairperson address.
Hello.
With that teaching session, yes.
Am I audible? Hello.
Yes, ma'am.
Yes. This is Dr. Priyadarshini Tiwari.
Yes.
First of all, I would like to congratulate each and everyone for this wonderful lecture. For Jyoti, Dr. Jyoti, she is hosting this webinar, which is very, very helpful for not only for the student, but also for the faculty members. I would like to heartily congratulate Professor P.S. Byadgi, sir, because out of his very busy schedule, he has given a lot of time for this webinar. And as a colleague, I'm his colleague, so I know that he is very much dedicated toward the subject and the knowledge. So he has shared not only he has shared his view, but a very detailed explanation regarding the anemia, the clinical findings, the laboratory findings, the interpretation, which was excellent. It was really a very wonderful lecture to hear. And even though I was in the meeting, I have attended this lecture. And I would like to say that the interpretation was very, very nice. And the best part of this was the case presentation, which was extraordinary one. So it was a very good case of anemia, how the anemia has developed. There are a lot of drugs which are responsible for the condition of anemia. Not only that, not only the etiological factor, but sir has also explained in detail regarding the mode of action of that drug which is responsible for causing anemia. And apart from that, he has also discussed in detail regarding the laboratory finding and also the treatment part, which was not expected, but he has discussed in very detail. So it was a wonderful lecture. I think all the students and the participants, they have benefited a lot from this lecture. I once again congratulate you each and everyone for attending this lecture. And in future also, there are very good lectures are there. So please do attend. Thank you very much. I would like to thank Dr. Jyoti Megdambar for giving me the opportunity to hear this lecture. And I am the part of very many lectures. I'm attending that. So it is a wonderful lecture and a wonderful job which is done by Jyoti. And as sir has said that the book is coming. So there are many contributors, and I am also one of the contributor in that book, which is there for interpretation of that. So you will be getting that in the near future. So once again, congratulations to everyone and thank you. Thank you very much. Thank you, Jyoti ma'am.
Yes, yes,
Thank you.
yes, ma'am. Yes, yes.
And
Just
Dr.
1 minute.
Renuka ji, this book is available from the Chaukamba. This is the clinical laboratory manual. So this
Yes,
the students can refer. Somebody
Sir,
has
show
asked about
again, sir. Badgi sir, show again. Students are taking photos. Show again. Sir, show again your book.
this one.
Yes. Students, PG students of Nanded taking screenshots of your PPTs as well as the photo of your book. So it's okay. So very much thank you, respected Dr. Badgi sir. Today's lecture was truly very, very excellent and very easy to understand. Of course, Ayurvedic interpretation book we are writing since I think since long 2 years. Since 2 years ago, we started that book, and within short period of time, it will be published by Chokhamba publication. So, sir, I sincerely thank you again, and we look forward to more such insightful lectures. So, thank you so much again, Dr. Badgi, sir. Thank you, Priyadarshini, madam. Now, over to Dr. Renuka for chairperson and co-chairperson's address. Thank you, sir.
Yes, thank you, ma'am. Now we shall move forward with immense pleasure to introduce our respected co-chairperson, Dr. Krishna Kadam ma'am, Associate Professor in the Department of Rognidan and Vikriti Vigyan at Government Ayurvedic College, Nanded. With over 16 years of teaching experience for both UG and PG students, she has been actively engaged in academics as well as clinical laboratory services, serving as an expert in the Central Pathology Lab. She has contributed extensively to research with over 30 publications and numerous presentations at national and international pathology, and has been recognized with awards for best PG thesis and best paper. Her active involvement as a resource person, chairperson, and co-chairperson in various academic forums reflects her dedication. Have you with us. May I now request you to kindly take the session forward and address the participants with your
Am I audible, Renuka?
insights.
Hello. Am I audible, Dr. Renuka?
Yes, Dr. Krishna.
Yes, ma'am. Yes, you're audible. Yes, ma'am.
Okay,
You're
thank
audible.
you so much, ma'am. Good evening, all of you. Honorable
Yes,
Head of the Organizing
ma'am.
Institute, respected Dr. Sampada Sant ma'am, and
You're
organizing
audible.
team, Honorable Chairperson, respected faculty, distinguished guests, and my dear colleagues and students. As we come to the conclusion of today's enlightening academic session, interpretation of hematological tests with a focus on erythrocyte dynamics through the fundamental principles of Rognidan Vikriti Vigyan. It is my privilege to put the keynote remarks as a co-chairperson for today's insightful guest lecture delivered by our esteemed speaker, Dr. Badgi sir. Today's session was truly enlightening and thought-provoking. Sir beautifully bridged the gap between the modern hematological parameters and clinical Ayurvedic diagnostic wisdom. The detailed explanation of RBC dynamics and related investigation with respect to anemia such as MCV, RBC count, plasma ion, TIBC, etc., was not just limited to numerical interpretation but extended into a deeper understanding through the lens of Raktadosha, Raktadhatu, and their Vikriti. This integrative approach made this subject more meaningful and clinically applicable. Sir's emphasis on understanding the Moola Siddhanta of Rognidan Vikriti Vigyan reminds us that true diagnosis is not merely about reports but about interpreting them with fundamental principles, yukti, and clinical reasoning. The way he corrected the erythrocyte abnormalities with Raktadhatu Kshaya, Bruddhi, and Drishti has enriched our perspective as budding clinicians. Such sessions inspire us to think beyond the textbook and develop a holistic diagnostic approach combining classical Ayurvedic knowledge and modern advancement. On the behalf of everyone present here, I extend my heartfelt gratitude to Badgi sir for sharing his immense knowledge, clinical experience, and valuable insights. We are truly motivated and benefited by this session. Thank you. Thank you so much, sir. Over to you, Renuka.
Thank you so much, ma'am. Yes, Yes, ma'am. Thank you so much for your thoughtful reflections. And now to bring everything together, may I take this privilege to introduce our respected chairperson, Dr. Zai Kini ma'am. She is professor and head of methodology and biostatistics at Dr. G. D. Paul Foundation's YMT Ayurvedic Medical College, Kharghar. With over 20 years of teaching experience, she has mentored numerous UG, PG across universities like MUHS, BHU, and NI. A master trainer in research methodology, accomplished researcher, and has contributed extensively at both academic and national levels, including her role with CCRA's Ministry of Ayush. She is also the recipient of several prestigious awards, including the Dhanvantari Award and Research Excellence Honors. Her journey truly reflects dedication. Truly honored to have you with us. I request ma'am to kindly share her words of wisdom.
Hello. Yes, thank you, Renuka. I think I'm well audible, right? Hello.
Yes, ma'am.
Hello.
Yes, ma'am. You're
Yes. First of all, I would like to extend my thanks to respected Dean Madam of Podar College and the entire organizing team, especially Dr. Jyoti Madam, my beloved friend, for inviting me on such a prestigious and very important, timely needed platform. Actually, Byargi sir is the well-known Rognidan scientist because he is having the most, you can say, informative and maximum number of books, which entire national, you can say, nation-wise, everyone of Rognidan is referring that. So it's my privilege to be a chairperson on such a son of Rognidan, SUN son of Rognidans, uh, very much informative and uh, precise lectures regarding the most important area where Rognidan is looking forward to do the research. Every time, all of us know that every time his all books are used to be very scientific and his all lectures are very much informative. He is famous for his scientific based, patient oriented, thorough knowledge. The way today he explains each and everything, which is truly based on scientific references of not only Rognidan, not only Samhita, but also research guidelines. Many of the things have been covered by respected Krishna Madam in her speech, because though we both are Rognidanian, whatever she is feeling, I am very much agree to it. But here I would like to focus on very important point that Sir has again remarked this thing. The interpretation of any of the pathological test should be done with the reference of case presentation as well as clinical symptoms, pathophysiology on the basis of Rognidan classics. Whenever somebody asks us, he tells us what is the interpretation of CBC or what is the interpretation of urine. As per the Sir's lecture, which is very much relevant and very much justified, again here I would like to repeat and conclude that whenever we seek any interpretation, Ayurvedic interpretation of any contemporary text, any pathological, radiological, any kind of modern test, then for that Ayurvedic interpretation, we have to take in consideration all clinical symptoms of that case, pathophysiology, in the respect of Ayurveda Samprapti, and in Ayurveda classic. So thank you very much once again for giving me this opportunity and for enlightening us, all of us. Thanks from myself, thanks from my department, and thanks from everyone of Rognidan fraternity. Thank you so much.
Really, thank you very much for one and all. So I'm leaving.
Thank you, ma'am. Thank you so much for your guidance.
जयगिनी मैडम, बहुत दिन
Yes.
के बाद दर्शन हो गया. कृष्णा मैडम, ज्योति मैडम, सब
सर
लोग
मैंने
का
तो आपको
दर्शन
पहचाना ही नहीं.
अच्छा.
आपका पूरा आकृति बदल गया.
I was thinking, नाम तो बैडगी सर का सुन रही हूँ और ये कौन दिख रहा है? So you are look like you transform like anything. You are the actual misal of what Ayurveda expects and looking forward for the best and perfect lifestyle. आपके lifestyle के बारे में तो everyone knows because you are Ayurvedic star, but I could see it is quite evident and visible that your transformation is amazing. Hats off to you. You are very determined. The way you are determined about your documentation, your books, same way you converted everything in your daily practices, lifestyle transformation. Thank you so much. Very nice to see you after so
Thank
many
you.
days. Thank you, Jyoti madam. Because of you, we got
Yes.
this opportunity to interact. Otherwise, it was very difficult to make सर के साथ मिलना और बात करना. तो अभी रोगनिदान के सूर्य है. Thank you.
Dr. Renuka ji and Dr. Jyoti ji ekdam working very hard day and night. And they are getting full support from the college also. It's very, very nice, very important. Thank you.
Thank you so
Thank
much.
you.
Jyoti madam, very much,
Yes.
very done and very much required to everyone.
Okay.
Most awaited things.
With that, we come to the end of this. So with that, we come to the end of this enriching session. Today's discussion has not just added to our knowledge, but has truly deepened our perspective. Thank you to our respected speaker, chairperson, and co-chairperson for guiding us so beautifully. And thank you to all the participants for joining this session. Until we meet again with another session of learning, stay curious, stay inspired, because in the end, it's not just what we learn, it's how. So have a wonderful evening ahead, and we'll update about the next sessions on the group.
Dr. Renuka, just 1 minute. All the participants, Dr. Badgi sir, Dr. Zaikini, for everyone, I just want to say I should I should mention here that I must thank you to the Dean, respected Dean, Dr. Sampada Santa Madam, my HOD head of the department, Dr. Santosh Girpede sir, our assistant professor, Dr. Samdeep Kale sir, and assistant professor, Dr. Renuka Sawant. This is all the teamwork, not only me and Renuka, this is all the teamwork. Our technical head is very, very expert, as you all know, that is Dr. Sandeep Kale sir. So this is teamwork, and I should thank all my team from on behalf of my HOD as well as on behalf of my Dean, Dr. Sampada Santa Madam. So thank you once again. Dr. Renuka?
Yes, ma'am. Thank you so much. Shall I declare that the session is over?
Thank you. Thank you.
Yes.